Good morning, everyone. This is Christine Friedreich speaking. I'm the Associate Scientific Director for the O'Brien Institute for Public Health, and I'm very pleased to invite you today to join us for the Anatomy of a Pandemic webinar entitled A Second COVID-19 Wave, Hard Realities and Difficult Decisions for Albertans. Next slide, please. Before we begin, I would like to take this opportunity to acknowledge the traditional territories of the people of the Treaty 7 region in southern Alberta. The city of Calgary is also home to the Métis Nation of Alberta, Region 3. Next slide. The Anatomy of a Pandemic series was developed by the O'Brien Institute for Public Health at the beginning of this pandemic as a means of informing the wider University of Calgary community, as well as a means to support authorities and governments in the response to this unprecedented scale of and the human cost exacted by the COVID-19 outbreak. I'm going to be moderating your session today. The recording of this webinar and past webinars can be found on the O'Brien Institute website at o'brieniph.ucalgary.ca. Next slide. We are very fortunate today to have 4 outstanding speakers for this webinar. It's been my great privilege to be working with 3 of them in the University of Calgary's COVID-19 Analytics and Strategy Working Group. The first speaker today will be Dr. Tyler Williamson. He is the Associate Director of the Center for Health Informatics at the Cummings School of Medicine, and he's also an Associate Professor with the Department of Community Health Sciences. He will be followed by Dr. Katrina Mullaney, who is an Associate Professor in Community Rehabilitation and Disability Studies at the University of Calgary. She'll be followed by Dr. Daniel Niven, who's an intensive care physician and health services researcher with a special interest in knowledge translation, use of best practices, and in particular the adoption of low-value practices. And finally, our last speaker will be Dr. P.G. Forrest, who is the Director of the School of Public Policy here at the University of Calgary, and he's also the James and Barbara Palmer Chair in Public Policy at the University of Calgary. We've asked these 4 speakers to address essentially 4 separate questions. Tyler will be addressing the question of what is the current status of COVID-19 in Alberta. Katrina will be looking at the implications for social and structural vulnerabilities. Dan will be looking at the current acute care clinical implications of COVID-19 in Alberta, and PG will be looking at the public health policy options for Alberta. Next slide. You will be able to ask questions today by using the Q&A box. We'll be monitoring that throughout the session. We've asked each of our speakers to speak for about 5 minutes, so we'll be hopefully leaving a lot of time for questions and answers. If you're joining us from Facebook Live, you can use the comment box, and you can also send us questions via Twitter at #O'BrienCovid19. So now I'll hand it over to our first speaker. Next slide. Dr. Tyler Williamson. Thank you very much, Dr. Williamson.
Good morning, everyone. Thanks, Christine. It's my privilege to speak to you this morning about the current situation in Alberta. I have the challenging task. I think that many of you probably follow this as closely as everyone else. There's lots of information being made about where we are. I'll point out a few key things. Try and focus on some of the things that I believe are most important that we need to be paying attention to. And we'll be glad to speak to more of the issues in the question period. Next slide, please, Steve. So I think we all know the number of tests that we're doing is, of course, increasing. There's no doubt that everybody knows that the number of observed cases continues to increase. This is already a few days old, and we know that the number of cases has continued to increase through the weekend. And so we see ever increasing numbers, and of course a increasing number of deaths, although that hasn't increased nearly as much as some of the others. Next slide. We also note that, if you look at the changes in the municipalities that are having large volumes of active cases, that has steadily increased. You can just see the increasing amount of red as we've moved into more than 100 active cases per 100,000 population throughout Alberta. We see that as recently as a month ago, there were very few, and now there are many, many places across the province where that's the case. Next slide, please. But I want to draw your attention to a few things, and I want to maybe focus in on a few different aspects that we need to get across here clearly. This is the active cases, which we know is increasing. This is kind of what we call a stock. So if you want to think about the concern that we always have, that we hear a lot about, is making sure that we don't overwhelm the hospital system, the healthcare system. That can be thought of as a stock in terms of the number of people either in the hospital or in the ICU, the number of active cases. And that can be thought of as sort of the level in the bathtub. The rates that we see daily is, of course, the speed at which, the rate at which, there's flow into that. But we need to be paying attention to the stock. So of course, that's a function of outflow and a function of inflow and a function of just how much, reserve or space there is to still fill the bathtub. We know that that's been increasing, and it continues to increase throughout the pandemic. But I want to draw the distinction between those two for you. However, despite all these increasing numbers, there may be some silver linings in all of this that I think merit some more discussion, and I'll show those in the next slides. Next slide, please, Steve. What we have observed is that the risk of severe outcomes has been going down, and there's many different things that many of my my co-panelists will speak to as to why that might be happening. But we do see definitely decreasing rates of hospital admission, of ICU admission, and perhaps most importantly, the decreasing mortality rate. This has gone down quite a bit actually throughout the time from March until now. Now that's not the number, that's the rate. So we need to make sure that we're drawing our attention to that. There's a number of different explanations. Like I said, some of my panelists will get into that. Changing age demographic, better treatment, more masking. There's lots of theories around what it actually is, but it certainly is decreasing. I'll show you quickly the last slide, and then I'll pass it off to Katrina. One possible explanation has been suggested that perhaps it's infecting, the infection is moving into less severe people who have lower number of comorbid conditions, pre-existing comorbidities, and that we see that across those that have none, 1, 2, or 3 comorbidities, that has been decreasing almost uniformly. So what we see is that the number of cases in Alberta is consistently going up. The stock is going up, the active cases, the hospitalizations, the ICU, but there is a modest trend towards decline in the rate of serious outcomes, including mortality. I'll pause there and turn it over to Katrina, and look forward to discussing that more in the questions.
Thanks, Tyler. Good morning, everyone. I'm going to talk a little bit this morning about COVID and vulnerability. And so if you are connected to O'Brien Institute, you've probably heard me talk a little bit about this before, the difference or the distinctions between the ways in which vulnerability emerges in our communities and in people's lives. But we'll focus it specifically around COVID this morning. And so I think a fairly typical understanding of vulnerability is the ways in which individual vulnerabilities are characteristics or experiences that individual people or families face. And so poverty, living in homelessness, experiencing domestic violence, people are vulnerable because of those situations that are unique to them. Another way of understanding vulnerability is at a more structural level. And the way I sort of conceptualize this is that vulnerability happens, or vulnerability can force people into difficult situations when forces beyond their control, like the job market or a pandemic or limited access to affordable housing, no access to affordable childcare. These are sort of structural issues that can either exacerbate vulnerability or in some cases cause it, in my experience. Next slide. And so vulnerability in COVID-19. So there is some research coming out now that's looking specifically at different subpopulations and subgroups that are impacted by COVID. And the City of Toronto produced a report a couple of weeks ago with some pretty alarming statistics really about who in Toronto is being impacted by this virus. And almost 80% of people with an active infection came from a racialized group. Almost half of those were living in low-income households, or half of people with COVID were living in low-income households. And a quarter of cases were happening with individuals who lived in large households, so 5 or more people. Next slide, please. And so when we look at poverty as an experience of vulnerability, either at the individual or at the structural level, there's been some research starting to emerge around what impact will COVID have on poverty rates. And so one of the things we grappled with in the early days of the pandemic is, will we see a new level of vulnerability? Will we see a new group of people who were getting by before, who were doing okay, who now will be sort of tripped into low-income situations, specifically because of COVID-19? And some of the predictions that are coming out are saying that we will see the highest rates of poverty globally that we have ever seen, like in the last 50 years or so. And that obviously the capacity and the ability for families to save and or spend in this situation will be deeply affected, and that it will be, on average, it will take families about a year to recover once we have sort of taken control of the virus itself. So that's a long time, and a lot of people potentially who could be struggling in the next little while. In Canada specifically, about 1/3 of people who were employed lost their jobs or had reduced work hours. And some communities have limited access to healthcare. So even in a country like ours where we have universal healthcare, there are barriers to access if there are costs involved, say with the cost of medications, transportation costs to get care, access to good family physicians, and in some cases, low-income communities often have other issues that they're dealing with, physical health issues that do actually increase the risk of infection from COVID-19. Next slide, please. And so in Calgary, I've been collecting some data from one of our 24-hour distress center call-in organizations, and they send their data every month. And there's been some really alarming shifts and this is Calgary specific. And so we're seeing really, really high rates of mental health issues in people who have never really struggled with issues previously. The one that was particularly alarming to me was the calls about suicide specifically. And so compared with, in September 2020, compared with 2019, suicide calls increased by 69%. That is very troubling in my opinion. And one of the top issues that people are calling about is isolation and loneliness. There is quite a bit of concern in stress levels for frontline staff. For example, working in homeless shelters, there are some folks who have been working nonstop without a day off since March. We have had a couple of outbreaks in our shelters. There is one in our shelter right now that is problematic. There are also a number of organizations who are facing funding cuts. And so as the need or the demand for social supports going up, particularly around mental health, we are seeing some issues with our agencies and our programs who will be losing their funding because of lost revenues, because of limited capacity for philanthropy, in addition to cuts from the government. So, you know, we could be seeing a bit of a perfect storm brewing here as these issues start to collide. And of course, this one is particularly problematic, I think, for me, in that we are seeing significant increases in the number of opioid overdoses when we were seeing some declines actually in those numbers prior to COVID. Next slide. So, silver lining, Tyler mentioned this as well. There are those of us working in public health that have been arguing for a very long time that social inequities are indeed public health problems. And I think COVID-19 is kind of like a flashlight shining on vulnerability, the ways in which it emerges, the ways in which vulnerabilities are impacted by our structures, by our policies and our programs, and these disparities and inequities that we're seeing in particular populations. You know, it's interesting to think about how do we respond differently if we think about these as structural problems. Next slide. And so a really quick example of how we're trying to address this from a community level. So working collaboratively with different agencies and partners who work on the front line with vulnerable populations and in social and structural vulnerabilities every day. We're going to do a study with low-income Calgarians, a broad survey to understand how COVID-19 has directly impacted their ability and their capacity to generate income, their issues with food security, paying their bills, the stability of their housing, changes to their physical and mental health. And the biggest question for me, and as we do follow-up interviews with different groups, is what would make it better? And so asking people who are living it every day, in my opinion, is the best way to understand how to do that. And so when you take a community engaged approach and your focus is what are the structural barriers, it opens opportunities to shift away from how do we change individual people's behaviors, how do we make them do better, how do we make them try harder, towards things like, is there a way that we could change at the public policy level or the social policy level that would have a greater impact on a larger number of people. And so one of the things that is emerging right now in the conversations across Canada is something called the Basic Income Program, which would be like the CERB benefit or an enhanced EI program, where people who are struggling to meet their basic needs would have guaranteed financial supports that could potentially alleviate some of the difficult impacts of COVID-19. I think that's it for me. Is there another slide? Nope, that's it for me. Thanks, everyone.
Hi, Daniel, you're on mute.
Sorry, you think you're a pro with Zoom and then you forget to unmute it. So I was just saying, I'm an intensive care physician in Calgary. We're predominantly at the Peter Lougheed and an assistant professor within the Cummings School of Medicine. And I'm going to speak to you about the acute care implications of COVID, specifically within Alberta, and why it's so important for us to get a handle on this and what can happen if we don't have a handle on this. So first, I thought I would just try to help us understand, what is severe COVID and why is it killing people? And in fact, impart upon you that it kills people despite the best care we can provide them. So, in this schematic here on the far right-hand side, I have day 0, which is your symptom onset. When you just start to feel, a bit unwell, and perhaps you feel really unwell, because COVID certainly can cause people to feel really unwell compared to their usual cold, but predominantly you're getting care at home. You don't need the hospital yet. Then predictably, for some patients, 3.5% or so within Alberta, by day 5 or 7, you end up in the hospital. And you end up in the hospital because you have an x-ray that looks like that in the middle, which is someone who's developed pneumonia, being infection in the lungs, not just in their throat and upper respiratory tract. So these people need oxygen and they're short of breath, so they come into hospital. And then by about day 7 or 12, the pneumonia really gets going, and the lungs start to fail, and they need more than oxygen. And you can see there that the lungs that normally had a bunch of black within them, which represent normal air, are now filled with white, which represents all the infection and inflammation that COVID can create. So this is about 0.6% of overall cases in Alberta, or 18% of patients that hit the hospital. So if you hit the hospital with COVID-19, there's a 1 in 5 chance you're going to end up in the ICU. And then in the ICU, the vast majority of these people, 2/3 to 3/4, end up on a ventilator to try to save their life. And in spite of that, in spite of everything that we can do for these patients, our hospital mortality for these patients is still 23%. And that's Alberta data, which is actually better than international data, where the estimates are closer to 40%. And so in spite of everything that we do for these people, a quarter of them, if they end up in the ICU, are not going to make it. And that's a pretty sobering number. Now, within the media, we've heard about the impacts of COVID-19 on the elderly, and certainly that's the case. That is a major driver of the outcomes in these patients is age and medical comorbidities. But it's also important to recognize that it's not just the elderly and the medically comorbid that die from COVID-19. This is a well-publicized case of a Canadian who died in a US hospital from COVID-19. So this is Nick Cordero. He's an actor. He grew up in Hamilton. He was 41 years old, good baseline health as far as what's been published online. No medical comorbidities such as those that you'd be used to seeing in these patients. He got COVID in March in the US, and he spent 3 months in a US hospital, all of it in the intensive care unit, receiving highly specialized forms of life support, such as what's called ECMO, which is where we essentially put the body on a heart-lung bypass machine. He had his right leg amputated owing to blood clots that occurred in his circulation. And towards the end of his life, when people were scrambling to try to figure out how to save him, he was considered for a double lung transplant. And of course, they didn't find a match because it's really hard to do that on short order. And so he died on July the 5th, 2020, leaving behind his wife and young child. And so, here's a healthy guy, and you may say, well, that's a one-off. And sure, it's true, but that's a big deal for him and his family for something that can potentially be avoided. The other important point I'd like to make is that the rapid, large influx of COVID-19 is going to significantly strain acute care systems. We see this internationally. This picture is from Wuhan, when they had their major outbreak back in March. And I could have provided you a picture from Italy or New York City, any of the places that clearly got overwhelmed with COVID-19. And the picture highlights for you just how much care these patients need. These patients are all on ventilators. Some of them, if you look carefully, are also on dialysis, which is a kidney support machine. You can see the providers are really dressed up in their personal protective equipment because this unit is geared towards caring for COVID. So they've all got COVID. So they just put their PPE on, and that's how they do conduct their day. So they're very resource intensive from the perspective of personnel required to manage the machines, the PPE or personal protective equipment required to keep them safe, the ventilators, the personnel. There are many personnel required to care for these individual patients, and I'll show you a slide of that coming up. And they stay for a while. So, the patients on average, if they get into the ICU, are staying around 2 weeks. Some longer, some a little bit shorter, but in general, around 2 weeks. So as Tyler mentioned, the numbers are a function of outflow. The outflow for these patients is not fast. They stick around and they require care for quite some time. And, as Katrina was saying, the burden of COVID-19 and specifically the lockdown and everything that comes with the isolation is substantial. And we're seeing this numerically in the ICUs. The mental health burden that we've seen in the last few months is incredible. The number of people who've, taken attempts on their life is just something we've never seen that number before. The picture on the left here is meant to represent the main figure from a paper published in JAMA recently, where they measured within the United States excess deaths occurring within a time frame relative to the preceding year. Having accounted for those that died for COVID, which obviously is substantial because it's in the US, there's still a significant number of people that have died over and above those that died owing to a specific COVID infection, which probably reflects exactly that, the mental health burden, the isolation, the social inequities. People are not doing well right now, and we're seeing that within the acute care system. The opioid use is at levels we haven't seen. You can see on the slide on the right, this was taken from an article in the Calgary Herald, where they had gotten data from Alberta Health that showed that, we were doing pretty well with regard to curbing the opioid epidemic. And certainly there was work to be done, but, it was improving. But in the last quarter, owing to what's probably the impacts of COVID-19, opioid deaths have gone up substantially, and we're seeing this in the system. And so the current COVID-19 trends with regard to increasing numbers of cases really threaten capacity within the hospitals. It's important to understand that ICU beds are a finite resource. And yes, we can talk about increasing the numbers of beds, and there's plans in place for that, but there's specialized equipment and specialized personnel. So though, yes, you can amplify the numbers of beds and ventilators, you can make, lots of ventilators, you have a harder time amplifying the personnel that are required to provide specialized care for these patients. Back in March when, most of the acute care system was shut down except for emergencies, we could draw from other areas that could potentially retrain and retool to become competent to work within the ICU. We don't really have that anymore if we, continue to want to keep the system open to the point that we can provide all the elective care that we need to. As I mentioned, these patients stay for a long time and they require significant amounts of care. And so filling the ICU beds with patients that suffer from COVID-19 really threatens our ability to care for people with typical illnesses that require ICU care, such as severe trauma. Your 20-year-old that gets into a car accident that has a severe head injury. We need to look after them. And so if our ICUs are filled with COVID-19, we may struggle with that. Cardiac care, there's many examples. And so without capacity to care for all patients, what ends up happening is healthcare systems may have to implement triage protocols to inform who actually gets an ICU bed because they are a finite resource. So this was a paper published in one of the main ICU journals where these authors sought to create a guideline that could be locally adapted and modified to do exactly that, which is to triage, who gets in and who doesn't get in to the intensive care unit. And as of current status, we have not had to implement anything such as this within Alberta or even within Canada, to my knowledge. But if we get overwhelmed, these are things that may be required. And so we need help. We need the public's help, and we need government support to help us. This is a slide or a picture taken from an article on the CBC from where I work at the Peter Lougheed, where you can see, there are a number of healthcare providers all gowning up, all putting on their personal protective equipment to go in and look after a patient with COVID-19. And if you count them there, you can identify that there's probably about 7 or 8 of them in that room. And what they're doing is they're going in to take a patient who's currently being cared for lying on their back and turn them to lying on their stomach, which is what we do for patients who are ventilated that have severe pneumonia. And it takes people to do that. And we have to flip them back and forth, within a 24-hour period. So these are labor-intensive patients, and we really need your help to look after them. We need the government's help. We need the public's help. And so, I would be interested in the discussion that follows here. And that's all I have.
Okay, I suppose it's me. Very honored to be here, very humbled after those 3 presentations. I have basically 2 messages today. The first is a message of humility, and the other one is a message of social cohesion. The message, I published my first op-ed on COVID at the beginning of March. It was written at the end of February with a colleague at UBC, and we're looking at the impact of COVID on the acute care system. And after that, I became very, very reluctant going public. And in part, it's because I was embedded in different networks of public health experts in the US and in Europe and here in Canada. And the more it was going, the less certain I was. The less certain I was about what was happening, and the less certain I was about what to do to face this the pandemic. And I know, and I'm sure a lot of people here today have plenty of certainties. I see that on Twitter, see that in op-eds, I see that in my mailbox every day. But for me, COVID has been a lesson in humility. The first thing I think we learn during this pandemic is that it's important to make good decisions, but the good decisions cannot redeem the bad policies, the policies of the past. And the textbook example, I think, for the years to come will be the Quebec long-term system. Most of the fatalities in Canada are patients or people that were in the long-term care system of Quebec. A system that was underfunded, a system that, where culturally the idea that you will just park the elderly in those institutions and forget about them. And this is the price to pay, even if Quebec after that took pretty good measures to try to contain what was happening. And you could say the same about what happened in France and in Italy, where their care models were clearly not prepared and were completely overwhelmed by the pandemic. The second thing we learn is that there is no quick fixes for inequalities. And I think Catherine make a very good point about this before, but it's clear. I was thinking of the absurd debate last week about the tracking app, the tracing app in Alberta versus the federal app. In fact, apps have played about no role in any countries in doing anything, but for a few exceptions. And so the problem we're dealing with is the very unequal distribution of the virus according to existing inequalities and vulnerabilities. I often start my presentation in seminars by saying we don't really know what to do. And by that, I mean different things. The first, I had this conversation with my friend Bill Galley Saturday. Let's say, for instance, we all know that to reduce the risk of amplification and clusters, we need to reduce the number of people that are allowed to meet together. But what's the proper number? Is it 25 like Michigan imposed last week? Is it 15? Is it 6? We don't really know. And this is a problem because we are used to have very clear sense of causation, especially in public health, that tells us what to do. And at this moment, we don't have this form of information. In fact, most of what we have learned through counterfactual. We have learned to the fact that, it's probably better that in the end we impose masking. It's probably better that we impose a lockdown. But we cannot know for sure. Again, we're in the world of counterfactuals. And finally, I think the last lesson for me is that it's still better to act late than never. And again, I could provide you with a lot of examples around the world what we have seen, like for instance in England, that after they have flirted for a while with this idea of herd immunity and the Swedish model, they understand at some point that it was important to introduce much more, let's say, invasive and direct measure of control. This sentence could have been written by my friend Patrick Fafard at University of Ottawa. We worked together on projects on trying to explain the role of public health officers in our system. But the basic idea there is that in the end, it's probably better than arbitration is left into the hand of politicians. And I know, because I could read that, there is a lot of impatience about the way politicians are making their decisions. But I still believe in the long term, it's the best solution. It's the best solution because we will never get perfect measures. We have to take into account the opinion of the public, their willingness to collaborate. This is something I learned in public health when I was doing my training, that it's easier to mandate some sort of public health norm when you already have a large part of the population that is convinced that this is the right behavior. And at this moment, in particular in Alberta, for all sorts of different cultural and historical reasons, we're not there. And it's probably important that we ask our politicians, our political leaders, to do this arbitration. So we are probably in there of, well, I say probably, because again, we don't know. The virus has its own temporality and imposes its own timelines. Remember, a lot of people now are, during the summer, our problem was the Swedish party. At this moment, it's people that want to replicate Melbourne everywhere. And Melbourne started with people saying it will be done in 6 weeks. It took them 112 days. We're there for the long haul, and so what to do? But the first thing is insisting on social cohesion. In Calgary, it may mean trying to find back the spirit of 2013, with, you know, at the time of the flood, and think of the solutions in terms of compromise. Public spirit for real, which means, you know, understanding that, you know, we cannot continuously integrate into the solution some private narrow interest, in that the interest of the population as a whole has to be taken into account. I mentioned the need for long-term perspective, but within this long-term perspective, I think that really irritated me with the Swedish approach at the beginning was this idea that when you have a plan, whatever happened, you never change. No, we need to be able to do real-time adjustments, which requires data, which requires also the capacity to link evidence with the decision-making system. Again, Kathleen spoke about this idea that vulnerability is not evenly distributed, and that we have to recognize that we will have to do interventions to address this question now and in the future. And finally, my last point, you know, resist all or nothing approaches. There is no perfect solution. We don't really know what to do, and we need to have a kind of trial and error approach to the interventions we're putting in place. Thank you so much for your attention.
Thanks very much to our 4 speakers. That was excellent. So we will now move to the questions and answers with our attendees at this webinar. Just a reminder to everyone who's listening, if you would like to ask a question of our speakers, please put that into the chat box. I will be moderating this session, and I will try to get as many of your questions answered as possible during this chat period, this question and answer period. And I have noticed that some of the questions have already been answered, so I thank Tyler. So maybe I can just ask all of the speakers to turn on your videos, and then we will be able to start directing questions to all of you. And I think all of you have access to the chat box as well, so that you can look at the questions that we've been asked. So looking at the first question here, we have a question from Chris Hilton. He's asking, he said he's familiar with the federal support programs for on-reserve Indigenous populations. However, there seems to be little available for off-reserve that, for example, city-based Indigenous populations. Do you have any comments or data on this population? So who would like to take that question?
I'll start.
Okay, go ahead, Katrina.
Yeah, it's a really good question. And this is not an issue that has emerged because of COVID. This is a long-standing issue. And so access to supports for Indigenous people is really complicated depending on where you live and what your status is, and whether you have documentation to prove your status. There's all kinds of complications associated with this. And so what I would say is, in the research that we have done around structural vulnerabilities in the city of Calgary, we know that Indigenous people are overrepresented in homelessness and in low-income households. We did a recent study with families in emergency shelter that was really heavily focused on racism and discrimination, and the ways in which intergenerational trauma is completely exacerbated by how we actually respond, which is very poorly, in my opinion. Now, the good news is there are some initiatives that are happening locally. The City of Calgary has recently launched an affordable housing strategy and are currently working on an affordable housing strategy specifically for Indigenous Calgarians. And so what we're doing is we're doing a scan of the capacity in terms of how many housing companies, how many landlords are offering units to Indigenous Calgarians. Are there culture supports made available? Are there partnerships that can be leveraged to make sure that those cultural supports are available, et cetera? And so I think what we're starting to see is some good momentum and some good potential and some good possibilities. But yes, we have a long ways to go. And for the most part, if you are living in Calgary and you are low income and you are Indigenous, you are probably struggling to find really good, safe, sustainable, affordable housing. And in my opinion, if you don't have housing, none of the other things matter. And so that's why I'm sort of focusing this answer around what's available for housing, because once that's in place and you have some stability there, every day is not about survival. It can be sort of about forward thinking and how can we move forward now, getting the other supports that we need.
Thanks very much, Katrina. There's actually another question that I'm going to direct your way, and maybe Tyler can jump in as well. The question is from Michelle Fry. She's asking, does Alberta have similar data to Ontario in terms of household size, income, race, and other descriptive data? Thinking to the provincial graphs shown by Dr. Williamson, how might Alberta's vulnerabilities look similar or different to those from in Ontario?
Mm-hmm. We do indeed. Some of the data, most of the data that we see or that is available comes from municipal census data. And so our cities collect information from households every year about income, about how many people live in your household, about education levels, all of that. And so we have been working, as Christine mentioned, some of us are on a task force. We have been working with folks from the city, and they have shared some of their data, and some of it is, we're looking sort of like at geographical data. So are there particular neighborhoods in the city of Calgary where we're seeing higher numbers of COVID than others? And so we are able to see, yes, there are neighborhoods in the city where that is happening. And we're also able to look at the number of people that live in those households. And yes, we are seeing that households with 4, 5 or more people are having higher rates. What I will say about that is when we think about what the problem is, I think about it in 2 ways. What are people doing in their personal and social lives to be safe? And what is happening in their workplaces? And what we know is that lots of people work multiple jobs to be able to afford to live in Calgary, which is still a very expensive city. And lots of those workplaces are not safe. And so I like to think about how can we hold businesses a little bit accountable? How can we make sure that they are having safe practices in place, allowing people to wear masks? I think the biggest barrier is paid sick days. And so if you get paid by the hour, you don't get paid sick days, and you are supporting a family, sometimes multiple members of the family, it's very difficult to be able to stay away from work, and that could be part of the problem.
Excellent, thank you. So I'm going to direct a question to Dan now. Are there reasons to why mortality is high regarding COVID-19 in the hospital? How does this number compare to other respiratory viruses?
Yeah, good question. So there's a couple of points there. There's a paper that was published recently that did a really nice job from the UK examining COVID-19 respiratory failure, so lung failure in an ICU, compared to influenza respiratory failure, again, lung failure in an ICU. And it's very clear that the patients in that cohort with COVID-19 related respiratory failure do worse overall. Now that's kind of before we had an effective treatment for COVID-19, especially the severe variety of COVID-19, namely steroids, which has been more widely implemented now since the publication of a number of trials that came out in June, where it's essentially become standard of care for people that come into hospital that need oxygen and then don't otherwise have a reason not to give them steroids. They receive steroids. So and this might be part of the reason why we're seeing some improvements in survival, as Tyler had showed there, related to COVID-19, is that we actually have a treatment for COVID-19 at this point. Whereas back in March, April, May, and even June for that matter, what we had was a ventilator, which doesn't treat COVID-19. It supports the patient while we hope that their body recovers from COVID-19. So that's in comparison to other respiratory viruses, where with influenza we don't have similar treatments. We have an antiviral, which is okay. We know it's not the greatest, but in fact steroids made those patients worse. And then as far as the mortality numbers go, That mortality number that I presented there for patients in Alberta that end up in an ICU with COVID-19, their hospital mortality of 23% is actually quite a bit less than other international estimates. Some of you may remember back in May and June, there were papers emerging from both Italy and New York City suggesting that ICU patients had a mortality of 80 to 90%, which was just staggering. You know, when you look more carefully at the UK data, which really more closely resembles our experience, we're still, you know, better than that, in that the UK data is around 40%, and we're 23%. So, you know, I think that speaks to the fact that we have not yet gotten overwhelmed, and we've been able to provide these patients with the absolute best care that they need, at paying attention to best practices and being able to do that carefully. Whereas if you get overwhelmed, then I think, you know, it's clear that you have to basically just keep your head above water, and you're not necessarily being able to provide them with everything that they need.
Okay, thanks very much. So we have a couple of questions that are similar that I'm going to group together, and this is going to be for all of the panelists. And so there are a couple of our attendees are wondering about your opinion on a value of a lockdown or circuit breaker, however you want to call it, that's being proposed by various groups and individuals in Alberta. We're wondering about the pros and cons and whether it is a strategy that we would support. So essentially, you know, what specific measures would be effective to help flatten the curve? So PG, do you want to maybe start with that response?
Yeah, so my understanding of what we are facing at this moment is, so basically we have two different issues. The first one is the issue of primary contagion or contamination, the original outbreaks. And I think here, my pet peeve at this moment is the US border and the need to address the problem that this porous border with the US is a huge problem, because we are reintroducing virus into Canada on now nearly continuously. And this is the problem. You cannot drain the bath if you have the faucet open, and that's our first problem. The second issue, of course, has to do with amplification of those outbreaks. And here, the first thing we need to address is the problem of crowds. This is something we know. We have enough international evidence to know that we have to reduce the opportunity for people to contaminating a large number of people. We need to address the problem of people that are gathered in not badly ventilated space. And we need to address the problem of, you know, risky direct contact at work, or of course in bars and gyms and the like. So you see, it's possible, probably still at this moment, for the reason Daniel just addressed, that we may still have the time to avoid going back to the type of strict lockdown that we have known in the spring. But for that, we need rapid interventions to address those three issues. And we have good models showing us internationally that this might work.
Okay, so I'm wondering if Tyler or Dan would like to also add there, or Katrina, your thoughts? Maybe Tyler first.
I don't have a lot to add, you know, to what PG just said. I think that he hit the nail on the head pretty hard. I think that the downside to the lockdown approach is that it's a very blunt instrument, and I think what PG's talking about is a little bit more precise instrument to try and to be specific in this, rather than just restricting all movement, you know, like the Melbourne approach, right? So it was also asked repeatedly, you know, what's the consequence of waiting? And so maybe I'll just jump in on that and say that, you know, I think it's key that we, you know, the actions now will pay dividends later. So we all agree, I think, that, you know, the sooner there is action taken, the better. The right action, I think, is, you know, I think a more precise approach, but certainly we need to do that sooner rather than later. And back to basic types of things. We need better contact tracing across the board, faster, that kind of stuff. You know, sort of the shoe leather epidemiology, as some have said previously.
Yeah, for sure. Daniel, did you want to jump in too?
Sure. Yeah. No, I think we definitely need action, and I think, as has been highlighted, you know, we know there's consequences to the blunt instrument approach. We've seen that all summer. just a staggering amount of health issues that we hadn't normally seen. So I think that would create more problems. I think what we need is a nuanced, data-driven approach that really places emphasis on the contact tracing, because if we're not tracing, then it really is running wild.
Okay, Katrina, did you want to add something on that? No. Okay. We'll go on then to the next. It comes from Mike Conroy. He, of course, is very interested in our long-term care and situation, and wondering about whether, since the largest mortality risk has been in the continuing care, and there hasn't been a meaningful provincial plan to protect these residents, despite all the learnings and challenges that we realized in phase 1. The concern here is this might be a systemic ageism, and we're wondering about how to protect these most vulnerable populations while addressing some of the economic realities. And possibly simply waiting for a vaccine would just further exacerbate this issue. Okay, go ahead, Tyler.
Yeah, great point, Mike. I really appreciate you bringing that point forward. Having an aged loved one who lives in one of those facilities, I'm constantly, thinking about and concerned about those issues. As we look at the models that have been successful across Canada, and I wouldn't say there's been any province that has particularly solved this problem. There's been a few locations that have done well. I think of Kingston, Ontario. They literally put guards at the door almost, where they had their inspectors standing at the door helping to ensure that nobody was entering the facility that had any symptoms. There are other things that were done. I definitely think that we need to be doing more, and your focus or thought to think more about the long-term care facilities is your point's well taken.
Yeah, does anybody want to jump in? Go ahead, PG.
Please. So last week I was asked to provide with a list of what I was thinking will be the research priorities for the next 3-5 years in health and social policy. And I put aging in number 2 and our aging policy, because the problem is not only a problem of biology, it's also a cultural problem. It's also an economic problem. And we need to, as a society, again, 80% of the fatalities of COVID in Canada are people aged 65 and more. This is terrible. It says something about our society. It says something, for instance, I mentioned that before, the toxic relationship between affordability for families and profitability in the private sector for people that are operating many of those centers. So when you put the two together, someone has to pay for that. And at this moment, and we're seeing clearly, it has been the elderly eaten by the pandemic. So yes, there are things we can do now, but in the long term, I think it's one of our priorities as a society. And of course, as part of the research community.
Okay, I think we'll move on. We have lots of questions here. So Judy Birdsell is wondering about how the public could potentially have a voice in how vaccines will be distributed within Alberta, to whom, at what priority, and why. Does anybody want to take that one on? Daniel, do you want to maybe handle that, or anybody else? It comes more into ethics. Nobody's, go ahead.
Yeah, that's a tough one. I think having public at the representation at the table, would be a useful thing for sure. Making sure there's a diverse group at the table that discusses the implementation of vaccines when available. Social media is very powerful. We've seen that for sure. So that'd be another way to get the public voice heard. Those would be my 2 thoughts.
Okay. I have a question that's come through from our Facebook attendees, and the question is, what are the top 5 things you would do now for both health and the economy if you were in a position to do anything?
I'll take the first one, so I'll take the easy one.
Okay.
I would increase the number of contact tracers, and we've talked about this repeatedly, as you know. We need, we cannot let the contact tracing be overwhelmed. It's just, it's just unacceptable in my mind that we have to have that happening. Even with increasing numbers of cases, that needs to be vital, and we need to find a way to organize and get, engage the community, whatever we have to do to make that a reality. That can't be a system that fails. So I'll take one. Who's next? Who's got number two?
I'll take one. This is, oh my gosh, this is such a hard question. One of the things that I'm really worried about is that we're not going to come out of this stronger and smarter and more coordinated in what we know about what to do. And so my hope would be that that we're really strategic and intentional about how we use evidence, and that we focus our evidence on some of the things that we've already talked about, like PG said, in long-term care and high-risk populations. So yeah, so I guess what I would do is I would say, let's get coordinated, let's get organized, let's be really thoughtful about what we actually know about what's happening, and be really smart and strategic and intentional about how what we learn and what we do with it in the future.
Mm-hmm. Great. Who wants to go next?
For me, and it's a counterfactual, but the most important lesson of phase one or wave one has been that we wouldn't have been able to go through this first lockdown without the massive financial help from the federal government, especially for individuals with low salary, low pay individuals. And I think this is so an important lesson. So if we have to go back into that situation, my most important preoccupation will be that we're seeing the same level of support coming for people so that they could stay home. Because if not, this is basically failure with a big F.
Okay, Dan?
I would couple to Tyler's contact tracing, a rapid testing strategy. And I know there's work done on that, and I know people have worked really hard to try to get testing facilities as optimized as possible. But I also know that there are still major delays related to the reporting of testing, such that for many people that's probably a barrier to go get tested. And then there they are with their COVID-19 not getting tested. So I think a system that was able to test rapidly, produce results rapidly, and then contact trace efficiently would be really advantageous.
Okay. I think we've also seen very good coordination at the beginning between the federal governments and provincial governments, and I think we want to make sure that that is even enhanced so that we really do work collectively in a sort of a common direction. All right, so we'll go on now. There's some questions, and this might be for you, Daniel. The government is providing a message of reassurance that we still have enough ICU beds and not to worry, when in reality that we have non-COVID care that is being severely impacted. So it seems like we're getting some mixed messages here to the public. So, what should we actually be thinking about that?
Yeah, I think we're at a point right now where, yes, we still do have ICU beds, and we have the capacity to flex up and open up more ICU beds. And there's lots of work that's been done there through our provincial critical care network that really has illustrated the power of that network, in fact, to be able to coordinate a provincial effort with regard to managing COVID-19. So there is the ability to create more ICU beds. The challenge is the personnel to manage those beds. And so, that's going to be, I think, the big barrier if we end up really getting overwhelmed and nothing, slows this down, is just, the personnel, whereby we had the luxury of drawing from, all sorts of personnel back in March and April, and people were really ready to go. We had lots of personnel on standby that luckily we didn't have to utilize. But now we don't have those because, people are back to their day jobs and, aren't as available. So I think the beds are there now, and I think, we have the ability to do more, but I think, I'm worried that if the numbers continue on as they are, we may reach a point where, that then becomes a major challenge.
Right. So I just want to tell our attendees that we're not going to be able to answer everyone's questions. I'm going to try to get through as many as we can. We are keeping a record of all these questions, and all of our panelists have agreed that they will answer your questions after this session as well. So I'm going to go down to Julie McLaren. She's asked a question here of PG, as she's confused by your statement that we don't know what to do. It seems we know many of the strategies that would support reduced burden and impact of this pandemic. Don't we need our public health leadership to strongly call for collective public and government action to address and reduce the impact of COVID? Also, trial and error in this case has a very real cost to human life. How do we balance the real and alarming insights that Dr. Niven shared with a see what happens view of public health measures?
This again, and I knew I will have this question, but I continue to think that, and when I say we don't really know what to do is, because I have seen again, look at what my Italian colleagues in the spring, they throw at this virus everything we know in the toolbox, and the virus in the end overwhelmed them. And we're always at risk of that. When I say we don't know what to do, of course, I'm a public health person, so I have a pretty good idea of the tools I will use now. But I think we have to stay humble and realize that the virus will have its own timelines, not yours, not Trump's, not Legault's, not Trudeau's. The virus has its own timeline and temporality. It will impose its own logic. And it's not a situation where I could very easily, there's many in public policy where you will show me the problem and I know I have a solution for you. And I know for sure that in 2 weeks, it will be over. It's not the case here. And this is, we have to try. Of course, my message is not a message of doing nothing. My message is to be humble and realize that we don't really know what will work.
Thank you very much for clarifying that. Next question is for Tyler. We have a question here regarding the mandatory contact tracing. The burden of this is currently falling on individuals themselves, which makes it extremely difficult if one is interacting with unknowns out and about. What can we do as individuals in this case? How can we help the system and ourselves?
Yeah, that's a tough question. I mean, the truth is that we're, like, even with the best contact tracing, we're never going to be perfect in it. We are going to interact with people that we may not know. I think the responsibility or the reality of the contact tracing, as we see happening elsewhere, is that some of that responsibility is being pushed to any organization that wants to allow people into their doors. So we see businesses being pushed, that responsibility being pushed off to businesses or other groups. Restaurants that are, doing contact tracing types of collection. So Sana, to your question, I don't know that an individual that's just walking down the street is going to be successful in being able to know every person they may come, walk past. But those are very, very low risk contacts, right? It's only the people that you're spending time near and for prolonged periods. And so I guess to answer, we just need to continue to be honest with the contact tracers and helping us to, to do our contact tracing if that's necessary. Encouraging those that there's no stigma associated with it, that we're clear and upfront about, hey, look, there's a potential exposure here. You really ought to get yourself tested out. And then, what we see is that groups are trying to do a better job of keeping that information to help facilitate that for people that may be entering their premises.
So unfortunately, I'm going to have to end the session today. I can see that we've had lots of interest. I just want to thank our panelists again for being so fully engaged, and also our audience. And we will definitely look at all the questions and respond to you. So thanks to everyone for joining us today. Lots and lots.